Okay, picture this. A child suddenly turns intensely, terrifyingly blue while crying. And weirdly enough, instinctively squatting down actually saves their life. Why? Today, we're diving into one of the most common cyanotic congenital heart defects in the world. Whether you're grinding through your MBBS, prepping for NEAT PG, or just want to truly understand the mechanics of this condition, this explainer is where it all clicks into place. So, we have to start with that fundamental question. What exactly is happening inside a tiny heart to cause such a sudden, massive change during a simple crying episode? I mean, why does a totally natural act like crying trigger a full-blown physical crisis? Well, the answer lies in a chaotic shift in the heart's hemodynamics. Here is our roadmap for today. We're covering the PROV anatomy defects, oxygen-poor blood and cyanosis, TED spells and symptoms, diagnosis and imaging, the surgical fix, and finishing up with a 60-second rapid revision. Section 1. The PROV anatomy defects. 4 abnormalities, 1 diagnosis. You already know TOF is congenital, present right at birth. But tetralogy tells us we aren't just dealing with one issue. We're dealing with 4 specific defects hitting all at once. For your exams, you absolutely have to lock these in using the classic PRO-V mnemonic. That's P for pulmonary stenosis, R for right ventricular hypertrophy, O for overriding aorta, and V for ventricular septal defect. Let's break down the actual plumbing here. Starting with the P, pulmonary stenosis. This is literally a structural bottleneck. You've got a narrowing of the pulmonary valve, or the outflow tract leading from the right ventricle to the lungs. Because this pathway is squeezed so tight, it drastically cuts down the blood flowing to the lungs to grab oxygen. And this one bottleneck, it sets off a dangerous domino effect. Which brings us to the R, right ventricular hypertrophy. This is simple cause and effect, right? Because of that narrowed pulmonary valve, the right ventricle has to work completely in overdrive. It's essentially pumping iron with every single heartbeat just to force blood through that tiny opening. So naturally, the muscle thickens and gets huge. Next up, contrast a normal aorta with an overriding aorta. Normally, the aorta sits neatly over your left ventricle, sending nice, oxygenated blood to the body. But in TOF, it awkwardly shifts. It straddles or overrides the V in our mnemonic, the ventricular septal defect. That's a literal hole between the 2 lower chambers. Because the aorta is sitting right on top of this hole, it's scooping up mixed blood from both ventricles, not just the left. Section 2. Oxygen-poor blood and cyanosis, the physiological outcome. Okay, what happens when you throw all 4 of these defects into one beating heart? Complete hemodynamic chaos. That pulmonary bottleneck builds massive pressure in the right ventricle, right? This high pressure forces deoxygenated blood to shoot straight across the VSD into the left side of the heart. That is your classic right-to-left shunt. And listen out, because this is huge for your boards. The severity of the cyanosis is dictated entirely by the degree of the right ventricular outflow tract obstruction. The tighter that pulmonary stenosis, the more deoxygenated blood gets shunted across the VSD and pumped out to the body. And that continuous loop of oxygen-poor blood, that leads straight to cyanosis. It's a very distinct bluish tint on the skin, lips, and nail beds. When you see that blue, you are literally witnessing tissues begging for oxygen. Section 3. TET spells and symptoms, clinical features of TOF. This answers our opening hook. Why does that crying baby turn blue? It's a TET spell. These are terrifying sudden episodes of deep cyanosis and extreme irritability, triggered when something like crying suddenly spikes the body's demand for oxygen. So why does a toddler instinctively squat, or why do doctors push an infant's knees to their chest? Because squatting literally kinks the femoral arteries. This causes a massive sudden increase in systemic vascular resistance. That higher pressure on the left side of the heart actually forces blood back across the VSD into the lungs, reversing the right-to-left shunt and literally saving the child's life. It's amazing. Beyond those acute TET spells, keep an eye out for other classic clinical signs. You'll see that blue tint flare up mostly during feeding or crying. You'll catch shortness of breath or dyspnea. Because their bodies are chronically starved of oxygen, these kids often struggle with poor weight gain and delayed growth. And a big one for your clinicals: clubbing of the fingers and toes. You'll see this in older children as a direct, long-term physical adaptation to chronic hypoxia. Section 4. Diagnosis and imaging. Spotting the defects. Thankfully, we don't have to guess here. While fetal ultrasounds can catch this super early, the echocardiogram is the absolute gold standard. It's the primary tool clinicians use to definitively confirm TOF right after birth. You can actually see the hole, the thickened right ventricle, and that overriding aorta in real time. Now, get ready for one of the highest yield buzzwords in all of medicine. If a board question shows you a chest x-ray with a boot-shaped heart or cœur en sabot, your brain needs to immediately scream Tetralogy of Fallot. That weird boot shape is a direct visual result of the right ventricular hypertrophy lifting the apex of the heart up. Section 5. The surgical fix. Restoring flow. At the end of the day, this is a mechanical plumbing problem, which means it needs a mechanical fix. Surgery is the definitive treatment, usually done before the kid turns 1. The surgeon goes in and directly attacks the anatomy. They patch up the VSD to stop that right-to-left shunting of blood, and they physically widen out the right ventricular outflow tract to relieve the obstruction and get blood flowing to the lungs again. And the really fantastic news, most children who get this repair go on to live totally active, healthy lives. But because their heart structure was surgically altered, they're for sure going to need lifelong cardiology follow-up just to make sure the plumbing keeps working as they grow. Section 6. 60-second rapid revision. High-yield facts. All right, let's lock this all in. Take a mental screenshot of this matrix right now, because these are the exact connections you'll be tested on. Anatomy, that's pro. The hallmark symptom, TET spells when crying, relieved by squatting. Main diagnostic tool, echocardiogram. And that classic, unmissable X-ray finding, the boot-shaped heart. So to wrap up this explainer, Tetralogy of Fallot boils down to 4 defects, 1 boot-shaped heart, and a lifelong surgical success story. But it leaves us with a pretty fascinating question to think about. As these surgically repaired infants grow into their 40s, 50s, and beyond, what entirely new physiological challenges is this generation going to present to the future of adult cardiology? Definitely something to keep in mind on your rounds.